Okay, now share screen. All right, so hopefully we are all working. All right, so this is where we get off my screen. Move someplace else. There we go. That annoying thing is going to kind of be in the way. But so we left off talking about the dumbbells mnemonic. Sometimes if you look, that can be a slightly shorter version, maybe just only 1B, 1S, but I just went over all of it just to talk about and reinforce parasympathetic control of the body by acetylcholine, what those effects are on the body, and then this condition when you have too much acetylcholine. Okay, so I know you've been dying to find out what the cure is and the treatment. So someone comes in, farmer's been exposed to insecticide that is leaving them in cholinergic syndrome, and this is what you want on your crash cart. The cure is pralidoxin, also known as 2-PAM for short. All right, so let me get my pen woken up today. All right, this is the cure. It restores the acetylcholine esterase, the enzyme, I'll put in parentheses, to break down acetylcholine. Because remember, whether you're exposed to organophosphate pesticide, sarin gas, whatever, it inhibits that enzyme. And so this drug, once given, will restore the enzyme. I won't go over the chemical means by the way it does it, but it's not like as you inject it immediately, they're fine. It's going to take hours to have an effect. So you got to do supportive care of your patient, keep them from crashing in the meantime while you're waiting for this drug to have its effect. So you want to treat the symptoms while you're waiting for the cure to work. So you're going to give them atropine. And this is what I gave the dog. Okay. And let me make sure this link is working. Give it a second here because my computer's doing a lot. Oh, there we go. Atropine. All right. Blah, 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 blah. Use, if you've ever had an eye exam, they give you atropine drops to dilate your pupils. To inhibit spasmodic contractions of digestion. All right. Inhibit stomach acid secretion in someone who has gastritis. Atropine is given IM to treat someone who's been exposed to nerve gas, which is an acetylcholinesterase inhibitor. We covered that. All right. Increases transmission of both nicotinic and muscarinic acetylcholine receptors. Okay, here's how it works. It blocks muscarinic effects of nerve gas. So dumbbells, pretty much all the dumbbells except for the sweating, which is muscle seizures, it stops all the dumbbells except that last S. So that's how it's going to help someone, right? So if we go back to the PowerPoint, get some of this crap out of the way, okay? It blocks the muscarinic cholinergic receptors to stop the symptom of dumbbells. So everything except that last S. All right. The diarrhea, the urination, the meiosis, the bradycardia, the bronchoconstriction, the emesis, the vomiting, the lacrimation, watering of your eyes, and the salivation, all of that is a result of muscarinic cholinergic effects of too much acetylcholine. So you're going to stop the diarrhea, all that stuff. All right. And that acts pretty quickly, like within a few minutes. Okay. How do you stop the last S, which is muscle seizures? Oh, let me back up. So if atropine blocks the muscarinic cholinergic receptors, it's an antagonist, it's a blocker. Is atropine an acetylcholine agonist or an antagonist? Antagonist, because it blocks the receptor. And we now know we really have experience an agonist or an antagonist from the T lab. All right, so hopefully that makes that real clear. Okay, so you got to stop the muscle seizures because if someone seizes uncontrollably, their body temperature rises to the point where it's deadly. And so you give them a Valium, which you've probably heard of. It's actually called benzodiazepine. And there's a clinical app for that online as well, but I'm going to skip it for now. Okay, this is, it's a muscle relaxant that stimulates or is an agonist to GABA. Okay, I don't know if I have anything else after this. Let me see. Okay, GABA we haven't covered yet, all right? But how many people have heard of Valium? It's pretty common, right? Okay, so it's a muscle relaxant. So if someone's got a muscle strain or something like that, and you want the muscles to relax so they have time for healing, you can use that. It's also, sometimes people take Valium because not only does it relax your skeletal muscles, because GABA is how it works, it stimulates that. It also quiets your mind. When you're in deep REM sleep, you're completely out, all right? GABA is the neurotransmitter that paralyzes your skeletal muscles so you don't get up and walk around when you're in deep sleep. And it also quiets your brain. So Valium does all those things, okay? So is Valium a GABA agonist or an antagonist? I already said it. It's an agonist, okay? And so that stops the muscle seizures. And so their body temperature doesn't rise, all right? Does all that make sense? Kind of gives you a glimpse into pharmacology and emergency medicine. And this would save the patient, to save the dog, okay? We didn't have TPAM, unfortunately, but we could stop all the other symptoms until eventually the acetylcholinesterase inhibitor will wear off. So, but in the hospital, you'll have TPAM, all right? Okay, easy peasy, 1, 2, 3, easy in terms of fixing your patient. Okay, now we're going to talk about toxins that affect acetylcholine signaling. Before we've talked about, I guess I'll call them poisoning, like organophosphate insecticides, sarin gas, and the other example I gave you. But here's some common things, common enough that you should know them in nursing, and I know you covered them in microbiology. Tetanus, all right? To be a student here, you have to be vaccinated for tetanus. A vaccine's good for about 10 years, all right? So tetanus is produced, the toxin, and that's the important thing, is produced by, Clostridium tetani. You learned that in microbiology. It's not the bacteria that's the problem, it's the toxin it produces. So the toxin is an acetylcholine agonist. It promotes muscle tetany, and I like to call it hypertonia because hyper means excess or high, and the tonia refers to muscle tone. Let me put it this way. Have you ever stretched in the morning and stretched your toes out and the toes lock up? Have you ever had that, like a Charlie horse? Extremely painful, right? When your muscles seize up in muscle tetany. Imagine that happening all over your body. Excruciating, okay? One of the first signs is lockjaw, known as trismus. And left untreated, it will proceed to all of your muscles in your body, eventually your respiratory muscles like your diaphragm, and you die. But fortunately, most people in the US are vaccinated. That's kind of a routine vaccination. So what tetanus does, it's an acetylcholine agonist. It also blocks glycine and GABA. Both glycine and GABA serve, both of these are for muscle relaxation. All right, both of those, we haven't covered them yet. We'll get to them today. So those relax your muscles. Tetanus toxin is a blocker to those neurotransmitters. So it prevents muscles from relaxing. So it's a two-pronged attack, stimulating too much acetylcholine, which causes muscles to contract, and preventing them from relaxing by blocking glycine and GABA. So you have that locked up muscles, excruciating. So you're supposed to get a tetanus booster every 10 years. If someone has gone past their 10 years, and let's say they got a deep puncture wound, and that's the classic exposure to tetanus, is a deep puncture wound, something where the puncture is small and the tetanus bacteria get into that wound, and then it seals over because it's just a tiny hole. Tetanus bacteria thrives in an anaerobic environment, and so that's why deep puncture wound. So if someone gets a deep puncture wound, they come in, and you have their patient history and you see it's been 20 years since their last tetanus vaccination, they need to get a booster. And to be on the safe side, you want to give them basically tetanus antitoxin. All right. So you get a booster, and that's going to take 2 or 3 weeks to have its effect to get antibodies. What do you do to protect the patient while the body's responding with antibody production? Maybe even a week. You give them antitoxin, which is a serum with tetanus antibodies. I'll say you inject a serum with tetanus antibodies. In that, the antibodies in that injection will find any tetanus toxin in the person's body, bind to it, and inactivate it. Here is an example of this. We have a lot of venomous snakes in South Carolina because of canebrake and cottonmouth, and then we have the most common bite from a copperhead, the most common venomous snake. Someone comes in, they got bit by a copperhead, and you go and you get the copperhead, the snake anti-venom. It's this. It's basically an injection of snake anti-venom, which is antibodies against that snake's venom, finds the venom molecules in the body, binds to it, and inactivates it. This does that, but with the tetanus toxin. And so you're going to protect your patient while you're waiting for their immune response to the booster you just gave them. All right. All right. So how many people knew all that about tetanus? Maybe not that it's an acetylcholine agonist, right? Okay. So let me make sure this app is online and my link's good. So this app is both for tetanus and botulism. So it's working. So you can look at that for additional reading. Okay. Now, toxins that are acetylcholine blockers. And I've got 3. And I try to include the ones that I think as nurses working in South Carolina, you might encounter. Okay. So the clinical presentation, what the patient presents with, is symptoms of not having enough acetylcholine. All right, this reinforces, you got to remember what acetylcholine does to the body, and then you can explain what happens when there's not enough acetylcholine. So botulism, produced by another Clostridium bacteria, Clostridium, oops, I hate it when it does that. Clostridium, okay, let me fix this in a second. Touch the screen and escape. Here we go. Come on, pen. There we go. My pen is giving me trouble today. Clostridium botulinum. It prevents acetylcholine from leaving, basically, from leaving the neuron. Okay. Remember, a neuron releases acetylcholine and acetylcholine enters the synapse. This prevents the acetylcholine from leaving. There's no acetylcholine in the synapse. All right. There's no acetylcholine, so there's no skeletal muscle contractions. This is babies who have been exposed to botulism because like they're given honey and they're not supposed to be and things like that. It's called floppy baby syndrome. I know that Dr. Pryor taught that in microbiology. But what it causes, it's called flaccid paralysis, and that's okay because flaccid means floppy. But I like hypotonia because hypo means low, and the tonia refers to muscle tone. Okay. All right. So it's an acetylcholine antagonist. And yes, this could be deadly if not treated, especially in someone who's young. How do you get botulism? You can consume food that's been improperly canned. And in an anaerobic environment, the botulism toxin thrives. It's got no smell, odor. Well, smell and odor are the same. Taste, so you don't know. Another way, can anyone think of another way you might get exposed to botulism other than improperly canned foods? What is this treatment that people take? It's an injection to get rid of like little wrinkles around their eyes and mouth. Botox. Botox, it's basically a small amount of botulism toxin that's supposed to be safe, but it paralyzes the muscles so you don't have the wrinkles. If people buy Botox and they're prescribed it from their doctor, they get it from a legitimate source that's FDA approved, fine. If you buy this crap off Joe Blow's website and you have no oversight, you can have botulism toxin that's too much or too active, and you can get botulism from it. All right. So could you possibly encounter this as future nurses? Yeah. Okay. There's also a botulism antitoxin that you can give. But yeah, you could encounter botulism. Here's something else. We've got a coast, and sometimes during the year they'll have warning signs saying, do not harvest shellfish, red tide warning. So paralytic shellfish poisoning, all right? When you harvest shellfish, that means clams, oysters, scallops, anything that's got a bivalve shell, something like that, that's shellfish. If they're harvested during red tide, the red tide is red algae. If you harvest during a red algae bloom, these red algae have a toxin. Oh God, I hate it when it does that. Called saxitoxin. Okay. It's also, it blocks acetylcholine nicotinic cholinergic channels. All right. It prevents sodium entry. So it's not blocking release of acetylcholine, not like botulism. Acetylcholine's, bless you, being released, but you're blocking the receptor, the ion channel, classic blocker. All right. So skeletal muscles can't contract because the receptor, the channels are being blocked. So it causes hypotonia, also an acetylcholine blocker. And yes, you could die from this. All right. Especially people who are really young, really old, or whose immune system is not quite a healthy adult might be okay. But yeah, if they have the warning sign, do not harvest and eat the shellfish, because what happens is they're filter feeders and they filter the water column for whatever goodies they can eat. And they filter and they take in that saxitoxin, and the saxitoxin actually builds up in concentration in the muscle. And it's the muscle of these shellfish that you eat. So you're getting a big, powerful dose of that toxin. And then lastly, not so sure that you will encounter this, but you never know. There might be some good sushi restaurants on the beach. All right. Pufferfish called fugu. All right. Have a poison gland that contains tetrodotoxin. This sucker will kill you. All right. The people who prepare pufferfish for eating have to be licensed for this, so they know how to carefully cut out the poison gland so that the flesh you eat doesn't have it. I personally myself am not going to put my life in the hands of some chef, even if they're licensed, because like, forget it. All right. Just don't eat pufferfish. Anyway, it does the same thing that the paralytic shellfish poisoning does. It blocks the acetylcholine nicotinic cholinergic channels, and you get the hypotonia. Okay, so if you go to a restaurant on any coast and they offer pufferfish, just skip that. It ain't worth it. Okay. All right, does that make sense? Okay, now I'm going to talk about other disorders that aren't poisons or toxins, and common things that you're going to see as nurses. So myasthenia gravis is an autoimmune disorder. We've talked about some autoimmune disorders. And this one causes your immune system to produce antibodies against your acetylcholine receptors. Okay? So what happens is it goes after, I'll say it attacks nicotinic and eventually, left untreated, muscarinic acetylcholine receptors. It starts with the skeletal muscle ones, because the first symptoms you're going to see in a patient is weakness in their extremities, and then even weakness in the jaw, weakness with the swallowing muscles, and eventually it goes after the cholinergic receptors, and eventually left untreated, it's going to paralyze your respiratory muscles and you go into respiratory crisis. All right, not good. If it's autoimmune, what would be a good treatment to start with to slow down the immune attack? Immunosuppressants, which come with their whole set of side effects. Okay, so I know someone who had this and died of it. It was in a retirement community in Florida, but it does go after your swallowing muscles. And so they become sluggish because they're losing receptors. And so people who have this have to be very careful when they eat or drink to do it slowly. So there's time for the epiglottis to cover your airway. And the guy I know, he had it and it was progressing, because even with treatment, you can only slow it down. And he swallowed and he aspirated it, which means it got into his lungs, and that he basically choked to death. So this is a common condition. You're going to see patients with this. Okay, Alzheimer's. You're going to see patients with Alzheimer's. We're finding out more and more about it. I talked about it, didn't write it down, but I said, it's due to a lot of things. I know the amyloid plaques, the plaque buildup in the brain, but also loss of acetylcholine producing neurons in the brain. In the brain, acetylcholine is always stimulatory. I had that on my chart when right. So it's stimulating activity in your brain. If you lose the neurons that make that acetylcholine in the brain, your brain's losing stimulation, and anything in your body that goes without being stimulated eventually atrophies. So here we have a positron emission scan of the brain, and all the bright orange, yellow areas are metabolically active areas of the brain. In someone with Alzheimer's, you see the increase of the more dark areas. That means those neurons that make acetylcholine have been lost, and those parts of the brain are no longer being stimulated, and they ain't coming back. And once the damage is done, we've now found, we haven't talked about this neurotransmitter yet, it's also due to excess glutamate, and glutamate is also stimulatory in the brain, but there can be too much of a good thing. Apparently, too much of this neurotransmitter is now being associated with Alzheimer's. All right, so you have memory problems. There's other problems. All right. I know someone who's got Alzheimer's, and I remember her over 10 years ago when she was normal, and I started noticing lapses in her memory. And now she's the point where I talked to some student, you actually work with her, right? And she doesn't know who I am anymore. Some days she recognizes her husband, sometimes she doesn't. And sometimes she's with it, and then other times it's just like her brain shuts down. All right. So anyway, I'm not going to write this down, but someone who has this disorder, there's treatments for it to help slow it down. You can actually, if you're losing acetylcholine, do you think giving this person a pharmacological acetylcholinesterase inhibitor would be good? If they don't have enough acetylcholine in the brain, give them a drug that actually inhibits the enzyme breakdown of acetylcholine so that there's more acetylcholine in the brain synapses, and it can help alleviate the symptoms. All right. You can also give them glutamate blockers. Now I'm kind of going off script here, but I want you to kind of think, if you know what the problem is, too little of this, too much of that, you might want to give them an agonist for the thing that's too little, give them a blocker for the thing that's too much. That's how it works. Okay. Okay. So what drug could you give a patient with low acetylcholine like Alzheimer's, or a loss of acetylcholine receptors like myasthenia gravis? Okay. Oops. Uh-oh. These things are supposed to go away, and they're not. Uh-oh. Okay. Well, anyway, I will erase these when I post the notes today, but you're going to give them an acetylcholinesterase inhibitor, pyridostigmine, neostigmine, they end in igmine, and they're a pharmacological drug to inhibit the enzyme breakdown of acetylcholine, and it can help alleviate some of the symptoms. All right. Not a cure by any means, because you got to find out why are the neurons dying. Okay. So since I can't show a lot of it, I'm just going to skip it, but it makes sense. I gave you acetylcholinesterase inhibitor, bad. But in this case, acetylcholinesterase inhibitor, good. So I'm giving you two sides. It depends. It depends on the situation. Okay. Now, I added this in here, and I think I made sure that the links work, because we're going to be talking about, we talked about this, we wrote it down. And then I went through acetylcholine and parasympathetic regulation of the body, rest and digest. Today, we're going to be going over the sympathetic when I introduce you to epinephrine. All right. Okay. So that link is working. Let's go back and check the key, make sure that's working. And there it is. Okay. So we've already covered this, not talking about the nerves. We're not going to do that today. All right. So moving right along. And this is, so we did this yesterday. We're going to do this today. Okay, so that technically is the end of the lecture quiz 1. I already sent you the breakdown of that quiz, so really just follow that email and you'll be fine. But now we're getting into the last part of this chapter, other neurotransmitters. Only the ones I think are relevant to you as future nurses. There's certainly a lot more than this. In nursing school, they might call the monoamine neurotransmitters catecholamines. All right, so no, this also means the monoamine neurotransmitters. So I wrote it down in a previous slide, but it includes dopamine, norepinephrine, which is in the brain. I'll put central nervous system, and epinephrine is in the peripheral nervous system. And all these are made from a single amino acid. Do not memorize this too much. And then dopamine plays a role in fine motor control. And we'll cover this more in detail. Also is a reward for pleasurable activities. It plays a role in psychological addiction. So people who have addictive personalities who are battling an addiction, every time they do something, whatever their trigger is that feels good, it could be food, it could be sex, it could be drugs, all right? If it produces that pleasurable sensation, what you get is a surge of dopamine in your brain. And that reinforces you to do that action again. And so people who have, there's physical addiction, and then there's psychological addiction. The physical addiction is minor compared to the psychological. That's the hardest one to break. And so some treatments for psychological addictions are to block dopamine. So remember the T-Lab? It's a sweet blocker. And so you're less likely to eat sweets because you're not getting literally the reward of, oh, that tastes so good, right? This, you don't get that dopamine release in your brain, that wave of, oh, that felt so good. You block it. And so you interrupt that addiction pathway. As nurses, you're going to be encountering patients that have drug addictions, especially you are aware of the opioid crisis we have. All right. So codeine, all those opioid-based narcotic prescription drugs, people are prescribed them for a legitimate condition, pain, recovering from surgery, joint surgery, all these things. But if they have an addictive personality, they can get addicted to it. And then they start doing this drug-seeking behavior, which you got to check. All right. Okay, and then serotonin, which I mentioned in that table before, 10% of receptors are in your brain and spinal cord. That's not a lot. So if serotonin is low in the brain, you've already got limited receptors. There's a lot of them in the gut, still don't know what it's doing. But serotonin plays a role in memory, moods, emotions, a whole bunch of other things. Okay. Now, these monoamine neurotransmitters are regulated by these removal systems. We talked about diffusion, enzyme breakdown, glial cell removal, and then reuptake. So reuptake primarily works with serotonin, all right, to remove it from the synapse. And so we covered this last time. I asked you, what are SSRIs? Selective serotonin inhibitors, reuptake inhibitors. One of the most commonly prescribed drugs for depression, anxiety, right? Like prescription number 1 in that category. Because serotonin is removed primarily by reuptake. It's not the only way it's removed, but it works best for serotonin. Okay. All right. Now, let me move this out of the way so we can see it. Come on. There we go. There's also enzyme breakdown of monoamines by monoamine oxidase, or MAOs. And I think I wrote that down when I was talking about acetylcholine. It breaks down dopamine, breaks down norepinephrine. Oops. Nope. Cancel that. Come on, I don't want that. I'm going to see if I can get rid of it. Here we go. Nope. There. Epinephrine and some serotonin. All right. Any monoamine neurotransmitter, which includes dopamine, norepinephrine, epinephrine, and serotonin, it can remove these. Obviously, SSRIs are best for serotonin, but there's a drug that will inhibit this enzyme, monoamine oxidase. MAOIs. Anyone hear of MAOIs? Monoamine oxidase inhibitor inhibits this enzyme. So it inhibits the breakdown of dopamine, norepinephrine, epinephrine, and also some serotonin. All right. And there's a couple of classes of it, like formulations of it. Let me get this further out of the way. All right. So if you have low dopamine, there's conditions where there's low dopamine, low serotonin. Most people don't have low norepinephrine or epinephrine. That's usually not an issue. You can give them MAOIs to build up those monoamines in the synapse by preventing enzymatic breakdown. So MAOIs, monoamine oxidase inhibitors, are monoamine agonists. So there's 2 types. There is this thing's not working, so I'm glad I brought this. There's MAOI type A or class A. It's an agonist to, oops, where's my pen? Here we go. Norepinephrine and serotonin. Okay, when I think of the A in MAOI class A, I think of A for agitation or anxiety, which in your brain, norepinephrine, in your brain, norepinephrine's causing that. All right, agitation, anxiety. It's your fight flight neurotransmitter in your brain. And I think of the A for serotonin because of appetite, because 90% of the serotonin receptors are in, I'll just say GI, and we don't even know what they're doing. All right. So if you have, and like I said, most people don't have low norepinephrine, but if you have low serotonin, why would, okay, so which would you choose to give a patient with low serotonin, depression, anxiety, stuff like that? Well, you can give them SSRIs because it is known to work really well. But what happens if in your patient SSRIs aren't doing the job? Oh, then let's try MAOIs type A, because we know that can increase serotonin. And if the SSRIs aren't working, try this, right? That's why we have many different ways to treat a condition, because people won't respond to one drug the same way. Okay, the other is MAOI B. And when I think of the B, I think of B for dope beat, all right? And I think dopamine, all right? Beat, if you're keeping a beat, you're using your hands, fine motor control, and dopamine plays a role in fine motor control. It's a bit of a stretch, but if it'll help you remember the difference between them, that can increase dopamine. Can you think of any disorder that involves low dopamine? And it is a muscular disorder. How about this? Michael J. Fox was in the news recently because he fell on stage to some event. Michael J. Fox. Does anyone know him? He's a former actor. He's kind of retired now, but he's got this condition that he has poor motor control or control of his muscles. Parkinson's. Parkinson's is a disorder that's characterized by low dopamine levels, and dopamine is for fine motor control. Okay, and so someone who has low dopamine, you might want to give him MAOI type B because it's going to increase dopamine and help him out. Right? Does that make sense? So if you want to read more about MAOIs, you can look at this clinical app. I'll double check that it's definitely working. Okay. All right. So am I presenting this and giving its application, nursing application? Does that kind of help make sense of it? That's what I'm trying to do. Okay. Serotonin. Keep track of my time. So again, there's a relatively few number of receptors in the brain. So if you have low serotonin, you already have a limited number of receptors, you can have profound effects. It regulates lots of things, not just what I have here, but memory, moods, emotions, behavior, even hallucinations. People who abuse recreational drugs that increase the amount of serotonin can experience hallucinations. That's why I've got this picture is basically supposed to represent someone who's on LSD, who's having hallucinations. And if you ever had a hallucination, some actual medical treatments can cause hallucinations. It's kind of a scary thing, all right? Low serotonin is associated with depression and also obesity, which obviously we have a problem in our country. Okay, so what can you give someone that will increase serotonin in the synapse? It's a serotonin agonist. So what have I given you examples of? SSRIs, which I don't remember if I have it, or MAOIA. Good. Okay. And then why would there be multiple drugs to treat the same problem? Not everyone's going to respond the same way to a drug, and so you try something different. Often treating a patient is a process of elimination. This doesn't work, this doesn't work, this doesn't work. Okay, narrow it in to find something that, dial it in, right? Dial it in. Okay, so serotonin and depression, obviously don't memorize this figure, but basically they're talking about serotonin released from a neuron. Let's assume it's in the brain and it has receptors, all right? If you give them an MAOIA, okay, it prevents the enzyme breakdown of that serotonin in the synapse. All right. Okay. Dopamine. So there's a lot with dopamine. It's produced in your midbrain. So from anatomy, you remember that what the midbrain is, all right? It's part of your body's autopilot system or life support system. So your midbrain, your pons, and your medulla are all part of your brainstem. Body functions that are so important for life that it's on autopilot. So in your midbrain, it produces dopamine by the substantia nigra neurons. They make the dopamine. All right. So dopamine's functions, fine motor control. That's the nigrostantial dopamine system. All right. When you have low dopamine, it's associated with Parkinson's disease, right? Like what Michael J. Fox has. All right. And the clinical app, let's make sure it's working. Yeah. And there's a lot. All right. There's a lot of information, much more information than I'm going to hold you responsible for. But definitely it talks about Parkinson's. Okay, so too little, bad. Too much, bad. Schizophrenia. Anyone know what schizophrenia? I knew one person who had schizophrenia. What would you describe schizophrenia as?
Well,
You can hallucinate.
but someone I knew said they would have like super low
Yeah. Paranoid, altered memory and cognition, which is thinking. Paranoia. Yeah, absolutely paranoia. I don't think I spelled paranoia right, but I'm not going to worry about it today. The woman I knew who had it kept telling me the same story over and over about how her uncle was going to visit and bring her a puppy. And her husband looked at me and said, her uncle's been dead for 20 years. All right. And she just refuses to let this go. Well, anyway, too much dopamine. Okay. Another part of dopamine, other than fine motor control in general, cognitive thinking patterns like schizophrenia, it's part of your emotional reward system. It is called the mesolimbic dopamine system. The limbic system does a lot. Emotional brain. That's what it's called in psychology, but it does so much more than just emotions. But addiction, okay? When you do something pleasurable, whatever that is, whatever you define pleasurable is, you get a dopamine release in the brain. So this is the psychological addiction. This is the powerful stuff this is the hardest hurdle for people with addiction is this psychological. All right. And like I mentioned, I'm not going to mention it here. It's just sometimes there's just too much, but you could give them drugs that block the dopamine release so they don't get what I call is the psychological cookie from whatever behavior they're doing. They don't get the dopamine release. So I've got an image here, which gives you an idea of the scale of the dopamine release. So let's say you're eating food. Okay. And they're showing in the brain, all right, the dopamine release, and it's a little bit of dopamine being released. And yeah, that tasted good, right? Basically, with cocaine or any of those really or the opioids, all right, the dopamine release is logarithmically greater. They get a huge dopamine release, reinforces addiction pathways. Okay. So anyway, this isn't an active link, I don't think, but if you wanted to read more about drug abuse as a future nurse, yeah, there's treatments for people. There's treatment centers. You're not going to be doing treatment in a hospital, but as nurses, you might recognize drug-seeking behavior and help rescue a person from this before it kills them. Someone on my street was addicted. He was, boy, was he ever, I don't know if it's crackhead or what, but he used to walk down, we have a long dirt road about a mile long, and he'd be walking down disheveled, like talking to himself, and I would just give him a wide berth, right? And he was on the drugs to block the dopamine release, but he still couldn't survive his addiction and he died of it. So it's a real serious thing, this drug-seeking behavior. Okay, more on drugs. Anything that can lead to a dopamine release can reinforce psychological addiction. So cocaine, methamphetamines, speed, drugs like that, okay? They are an agonist to all those monoamines. Dopamine, psychological addiction, serotonin, and norepinephrine. So people who are jacked up on cocaine, they can have hallucinations, too much serotonin. They can have muscle tremors, and the psychological addiction, too much dopamine. Some of these people can be really strong because they're jacked up on epinephrine in the brain. I'm sorry, epinephrine in the body and norepinephrine in the brain. And they're completely like full fight flight. You encounter someone who's high on cocaine, gonna have to strap them down, okay? Because they're gonna be really difficult to handle. But anyway, agonist to all those monoamines. Okay, now we're getting into the other part of that flow diagram. The nursing program wants you to know this. Norepinephrine and epinephrine. Norepinephrine is called noradrenaline and epinephrine is called adrenaline. All right. So based on that, all right, receptors have adrenaline in the name. Okay, and I'll show you shortly. Adrenaline is in the receptor name, just like the receptor for acetylcholine is called cholinergic. The adrenaline receptor is called adrenergic. All right. Okay, so epinephrine's in your peripheral nervous system. That's that flush you feel in your body when you have a fight-flight response. And we're going to talk about what happens in the body in response to this. Norepinephrine is in your brain, and so that stimulates your brain. And so I mentioned before, when you're in fight-flight, it seems like everything around you speeds up. Or no, sorry, everything around you slows down. And you are not slowing everything happening around you. What's happening is your brain is processing at a high rate of speed. And so you're thinking faster, which could save your life. Okay, so before I get into this and talk about the receptors, just look at me. We talked about rest and digest, ruled by acetylcholine and muscarinic and cholinergic receptors. What happens to heart rate, blood pressure, GI activity, urination, medication. Okay, blood flow to the gut. Flip it. Now we're on fight-flight. Epinephrine, known as adrenaline, it's going to work by adrenergic receptors. I'm going to teach you 3. There's more. I'm just going to teach you 3. Now it's fight-flight. Now what happens to your heart rate? Goes way up, which makes your blood pressure go way up. Your body is speeding the transport of oxygen and glucose around your body, which can help you. And that oxygen, glucose, the blood flow to your brain goes up, blood flow to your skeletal muscle goes up, because that's going to help you, your fight or flight, right? What's happened is digestion going to save you in fight flight. Your body's going to shut all that down. Shut down systems that aren't going to save you and activate systems that are going to save you. So all things GI shut down. Peristalsis, gland secretions in the GI tract shut down. You get dry mouth because your salivary glands go dry. Blood flow to the gut is restricted. Why waste blood and oxygen and glucose to a system that's not going to save you? So blood flow to the gut is going to be shunted away. What about, is it a good time to stop and go potty? No, that'll get you killed. All right. So inhibit or shut down urination deposition. Right. All that makes sense in a fight system, right? And there's going to be increased blood flow to your skeletal muscles because they're going to help you. They're going to save you. Okay, so if all that makes sense, let's talk about the receptors by which those things work by. Okay, so alpha adrenergic receptors. I've got an apple here. What do you do with an apple? Eat it and digest it. So when you think alpha, think apple. So alpha adrenergic receptors, and that's the symbol for alpha, are found on GI smooth muscles. So it will affect peristalsis. And it will go down. It's found on glands, decreased secretion, and also smooth muscle of arteries to the GI. You'll actually get vasoconstriction. It will vasoconstrict. You want to limit blood flow to the gut, not stop it so the tissues die, but limit it. Don't waste valuable nutrients and oxygen on a system that's not going to save you. Shut it all down. All right, so alpha adrenergic receptor shuts down GI stuff. In fight flight, ain't gonna save you. Don't have it be active. Okay. Beta adrenergic receptors, I'm gonna give you two. So I've got the heart. You've got one heart, right? Beta 1 adrenergic receptor, you got one heart. It's the receptor on the heart. It will decrease heart rate. So backwards, increase heart rate. Right? It's fight flight, your heart rate goes up. So beta 1 adrenergic receptors are found on your heart's pacemaker to be exact. So when you have fight flight and you get a surge of epinephrine in your body, epinephrine binds to the beta 1 adrenergic on the heart, receptor on the heart, and your heart rate skyrockets. And it speeds the rate at which oxygen and glucose gets to your body. All right. So I think beta 1, beat, 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 one heart, beta 1. Okay. Now, you got two lungs, right? Beta 2 adrenergic receptor is found on the smooth muscle of your bronchioles. Okay. It will cause there's either bronchoconstriction, which narrows your airway, or bronchodilation, which opens your airway. Which do you think is going to be more important to do in fight flight? Limit airflow or increase it? Increase it. Bronchodilation. Okay. Open your airways. Okay. More oxygen. That's going to help you in your fight flight. Provide more oxygen to your brain, to your heart itself, to your skeletal muscles. You're going to need that to get away or fight. Now, I also have arteries going to your skeletal muscles. That also works by beta 2 adrenergic receptors. So it causes vasodilation of arteries to skeletal muscles. So the way I remember the beta 2 associating with the bronchioles and then the blood flow to the muscles is, I think, well, you have two lungs, beta 2, and it opens them up, maximal airflow. When I think of beta 2 for the blood flow, I think the beta 2 adrenergic receptor is best to, I may change it to 2, best to get away. Okay, it's called fight flight. You need a lot of blood flow to your skeletal muscles in case you have to fight or in case you want to get away. You need that blood flow. So best to get away, beta 2 adrenergic receptor. So when you have this test, or way in the future when you have pharmacology, if you remember these, it'll help you out. Okay, so now, backing up. Now, since I've introduced beta 1 adrenergic receptors, okay, and when those receptors are bound to the neurotransmitter, it will open up sodium and calcium channels and your heart rate skyrockets. All right. Now, when I talk about beta blockers to bring blood pressure down, that's how they're working. And now you know how a blocker works. You've experienced it with the T. This is simply those drugs block that receptor so your heart rate stays low, your blood pressure stays low. All right. So everything I'm giving you is going to be relevant to nursing and common conditions that you're going to see. Okay. Now that's a big one, all right? And the flow diagram is the best way to go over this, okay? So what I'm going to do is I'm going to escape for the moment, and I'll pick up on the rest of this after break. But what I want to do is keep that and escape and make sure we catch up to where we are. We are, there. Okay, the flow diagram. I've got it pulled up. So let's do this. Let's reinforce this. All right. So we've covered this in the left-hand side, but now we're covering this right here. Okay. So let me get my pen going here. Come on, pen. And we want to skip for now. Nope. I want the X. We're going to skip the nerves for now. I won't get to that until chapter 4, part 3. But it's all working by, so this is, I need my keyboard. Sympathetic is fight, flight. Okay, you're in emergency, your life's at risk. So now what happens to your heart rate? Increases. Okay, and that makes your blood pressure go up because it follows directly. Your body is increasing the rate at which oxygen and glucose get to the systems that are going to save you. If it's fight flight, your bronchioles are going to do what? Bronchodilate. Bronchodilation. You want maximal airflow. If it's GI everything, down. Decrease. GI secretions, decrease. Blood flow to the gut. What are the arteries going to do? Vasoconstrict. Don't waste oxygen and glucose on a system that's not going to save you. But what about arteries going to skeletal muscles? Can skeletal muscle save you? Yeah. Vasodilate. Okay. Urination, defecation is a good time to stop and go potty? Hell no. Okay. Now, I know you're thinking, but how about when I have fight flight? How about people who piss themselves or shit their pants, right? Okay. Especially urinate on yourself, okay? Your body's still inhibiting those in fight flight. What happens is you're tensed up. And the increased pressure from all those muscles tensing up increases abdominal pressure. And that pressure overwhelms your bladder sphincters, all right? And so the urine actually escapes out because there's so much pressure on it. Same thing can happen in your colon, all right? The sphincter can only withstand so much pressure. And so it's an accident of the body, all right? Okay, now here's the big one, and we can take our break after this, but I do think this is time well worth spending. All sympathetic responses in the peripheral nervous system, because I've talked about peripheral nervous system here. What's the neurotransmitter that rules your fight flight? Known as adrenaline. And it is going to be adrenergic responses. Yes, it's epinephrine or adrenaline. Oop, sorry about that. Now, I don't know what that is. Okay. Now, beta 1. Come on, wake up. I'll just put B1, adrenergic. What does it control? Heart rate. Okay. Alpha. Oh, stop doing that. I'll just put, you gotta laugh. All right. Alpha. I'll just put alpha. I'll put a big A, alpha, adrenergic, because I don't want to try and use symbols. What's that controlling? All things G. Really? Really? All things GI, but shut it down. Beta 2. I have no idea. Let me move this over here. Maybe that adrenergic. What's that controlling? Bronchodilation and vasodilation of arteries 2. Oop. Huh? This is a big one. This is a big physiology one, okay? It's a lot to take in, but I know the nursing program wants you to know I know you're going to need it in Farm 1. Okay, so these flow diagram, I've taken time in class to go over it with you. That means go over it, right? So for exam 2, I am not going to be covering the epinephrine signaling pathway, all right? It is just going to include the acetylcholine and then some other chapters, which I may or may not get to today. I don't know, we'll see. And if we don't get to the information I need to get to by Thursday's lecture, I might change the exam a little bit to take that off, but I thought that was worth going over. Okay, so let's take our 5-minute break because God knows we need it now, right? Okay. And we will pick up where we left off. How much more do I have to go? Oh, wait. Oh, not much at all. Okay. So let's get the next chapter up.